Today we have a fantastic speaker, Dr. Joel Teitelbaum. He's professor and director of the Hirsh Health Law and Policy Program and co-director of the National Center for Medical Legal Partnership at George Washington Milken Institute School of Public Health in Washington, D.C. He also carries a faculty appointment in the George Washington School of Law. He's taught courses on healthcare law, healthcare civil rights, public health law, and minority health policy. Professor Teitelbaum was the first member of the School of Public Health faculty to receive the university-wide Bender Teaching Award. He's received the school's Excellence in Teaching Award and is a member of the GW Academy of Distinguished Teachers and the school's Academy of Master Teachers. Over the last decade, he's given us some of the most thought-provoking and interesting Grand Round sessions on topics ranging from legal health partnerships to the Affordable Care Act. I personally look forward to his talk and always come away from it with new information and new inspiration. Thank you, Dr. Teitelbaum, for giving us this year's annual Dr. Hirsh lecture on the topic of equity, law, and COVID-19.
And thank you, Sean, for that introduction. And as always, for all of you inviting me to speak. Year in and year out, I really enjoy our hour together each spring or summer, whatever the case has been. My only regret is that this year I'm not joining you today in the Goldberg Auditorium, but we'll do our best. I really enjoy this event in part because I get to talk about Harold. My colleague, Sarah Rosenbaum, and I reminisce about him often, but each year around this time, I go back and I reread his obituary and his eulogy. For those of you who didn't know Harold, his credentials were unassailable. He was a successful physician, lawyer, professor, researcher, and businessman. He was the author of some 300 articles and 15 books, and a sought-after editor of both medical and legal journals, and a wide-ranging philanthropist, including his endowment of this annual law-related Grand Rounds lecture. He was also a professional mentor to me and something of a stand-in grandfather for the 12 years that I knew him. I met him in 1997. My own grandfather died in 98, and until Harold passed in 2009, he was the still living version of my grandfather. Brilliant, feisty, funny, generous, and concerned about the state of the world. And of course, no mention of Harold can go without also mentioning his wife, Jane, who was his equal and his partner in all things. They were married for an unbelievable 68 years, and she died just 7 months after Harold did, literally of a broken heart. In any event, I should mention that on yesterday's Health Affairs blog, there was an essay called No Longer an Elective Pursuit, the Importance of Physician Advocacy in Everyday Medicine. And I can promise that if Harold were here today, instead of me speaking with you, he would want you to read it. So let me move on to the topic at hand. The general topic of this year's lecture was evident back in March. And unfortunately, for millions and millions of people, the pandemic offers up way too many ways of thinking about and discussing inequity. Given the time constraints, I had to slice off just a tiny piece of the COVID pie as it relates to law and equity, and I hope I have done so compellingly. As I'm sure you've all been experiencing in your own practices, there is just a ton to cover. Equity law and COVID-19, huge topic, obviously. Here's how I've thought about breaking it down just a little bit on background, a few slides on health equity and COVID-19, although my guess is you'll be familiar with most of those numbers, and then some COVID-19 driven legal issues. I'm going to provide a background slide on just how much is going on at the space of law, health, and COVID. And then I want to focus in on two specific topics, one of which is getting a ton of coverage in the press, and the other one that is basically getting none, that first one being eviction, and the second one is preemption, and then a couple of concluding thoughts and hopefully some questions or discussion. So let me start with some background, and there's only really, for my money, one place you can start here, which is with our nation's key pre-existing condition, which is systemic or structural racism. I use terms interchangeably for the most part. There are slight differences, but we'll use them both to mean the same thing. There are really two ways you can think about systemic and structural racism from a definitional standpoint. One is sort of the moment. So the first definition on the left is systems and institutions that produce racially disparate outcomes regardless of the intentions of the people that work within those systems and institutions. The second way is a more historical approach, which is the ways in which a multi-generational network of rules and practices are used to disadvantage those in power while disadvantaging the powerless. So whatever definition you can relate to, the easiest way to think about this is a form of racism that is embedded as normal practice. So this pre-existing condition is spinning off many symptoms, including the ones on this list, with which the nation has learned to live, even if somewhat uncomfortably, for a very, very long time. We are now looking at 40 million people living in poverty, massive wealth inequality, which is something I'll touch on, unequal education systems across the country, currently 27 million people uninsured, 2.3 million people in jails and prisons, but that number obscures a much larger number. About 10 million people every year are funneled through the jail system in this country. Political disenfranchisement, adverse childhood experiences, and toxic stress. Now, this list, as problematic as it is, you have to recognize that there's not a single thing on this list that isn't borne far more harshly by communities of color. So that always has to be in the background of everything that we're talking about. So let's talk a little bit about wealth inequality as one of the symptoms of our nation's pre-existing condition that is systemic racism. We face historically high levels of wealth inequality in the US today. In 1980, the top 1% of earners earned 27% more than the bottom 50%. Today, that number stands at 81% more. And today, the top 1% hold as much wealth as the bottom 80%. So what does that mean in reality? Well, so pre-COVID, so this has nothing to do with the effects of COVID. There was a study done, I think it was done by the Census Bureau, and they found that 40% of people in this country could not pull together $400 without borrowing it. During COVID, we have seen 45 million newly unemployed people. We're seeing about 1 million new cases every week on top of that. And yet the stock market has created 29 more billionaires since the start of COVID. In the US, the top 12 billionaires have a combined net worth that is just over $1 trillion. That's a staggering number, given that that $1 trillion represents 1/20th of the entire US economy, and the US economy represents about 1/4 of global income. Sorry, I'm having a technical issue here. Got it. Let's see how that plays out in a racial context. So US billionaires, not the 12 that I just mentioned, but all told, US billionaires hold about $3.5 trillion in wealth, or 76% of all Black wealth and more than all Latinx wealth in the country. The combined wealth of the top 12, that $1 trillion that I talked about a moment ago, is equivalent to the home equity wealth of the entire Black population in this country. And the combined wealth of the top 70 billionaires is equivalent to the home equity wealth of the entire Black and Latinx populations. So this racial wealth divide is where the past shows up in the present. This is systemic racism in a nutshell, as it reflects the glaring gap in wealth and the multi-generational history of white supremacy in the US and the systematic denial of wealth building opportunities for Black people and Latinx people. Chattel slavery, Jim Crow, segregation, still trying to figure out the technology here. Chattel slavery, Jim Crow, segregation, and predatory loans are reflected in the wide disparities in bank accounts of Black and Latinx people. Let's look at health equity and COVID-19 for just a few slides. So the US has about 4% of the world's population, and yet we are responsible for 24% of all infections and deaths. I've taken sort of a cross-section here from different parts of the country using different populations. You can do this really in any state, in any locality, using any distribution of race that you like. So Native Americans in New Mexico, they make up 11% of the population and yet 40% of the infections. Hispanic people in Montgomery County make up 20% of the population and 74% of the infections. And at every age range, Blacks are dying at the same rate as whites who are a full decade older. So I want to just mention a couple things about the COVID response in the country, especially when you're thinking about it in the case or in the context of race and ethnicity. Because when you stop to think about just how disproportionately the communities of color are being affected by COVID, everything that you talk about just gets amplified that much more. So as of this morning, the US has registered about 5.5 million cases of COVID and 172,000 deaths. CDC says that number could be 10 times that, but we'll just go with that number, 5.5 million, 172,000 deaths. Vietnam is a country of 97 million people, not a small country, and they share 900 miles of border with China, and yet they have recorded just 993 total cases, and it was only a few weeks ago that they recorded their first COVID-related death. They now have had 25 COVID-related deaths. The second thing, the next time that someone wants to talk about American exceptionalism, I think you can point them to our COVID response. We reacted like a developing nation with a shoddy infrastructure and a deeply dysfunctional government. Civilians had to take out their sewing kits to try and keep all of you healthy and to keep your patients alive. And we, the world's richest power, was sent humanitarian aid by the likes of Egypt, South Korea, and the United Nations. This slide breaks down by race the likelihood to have died from COVID compared to white Americans. So you can see that Black people have almost a 4 times greater chance of dying from COVID. This number was taken as of July 7th. The more recent numbers that I've seen indicate that we might be creeping up closer to 6% or 6 times the rate of likelihood of death from COVID than those of white Americans. Indigenous people back in July stood at 3.2, Pacific Islanders at 2.6, Latinx 2.5, and then the Asian population at 1.3. So here's a couple things that we know from the research. This is all pre-COVID, but it has enormous COVID consequences. Societies with smaller gaps between rich and everyone else do much better in fighting infectious disease than more unequal societies. We know this from OECD research comparing countries. And we also know that states with a higher number of inequality here in the US have experienced a higher number of COVID-19 deaths. So let's talk a little bit about legal issues. This is an overview slide. So I serve on an American Bar Association task force that is looking at legal needs arising out of the pandemic. And we put a survey into the field for legal aid providers to see what they were experiencing on the ground. This list gives you a sense of the kinds of issues that those legal aid providers are seeing on behalf of patients. So we've got unemployment issues, but also employment issues, as all of you are deeply aware. The loss of health insurance and what it would mean to gain back health insurance, housing, including evictions, which is something I'll touch on, understanding new government benefits and mandates, because obviously the benefit situation seems to be changing certainly monthly. And with the new mandates, people have questions about, are they in fact mandates, and what does it mean, for example, for people with disabilities who in wearing a mask may not be able to communicate as well through lip reading as if they are not wearing a mask, and issues like that. Lots of consumer issues, price gouging, scams, and debt collection among them. Domestic violence, I just saw a figure this morning that said that domestic violence and abuse treatment centers across the country have seen 40,000 fewer cases than they would have over the past 3 months. Again, raising fears that there is a lot of non-reporting going on in the domestic violence world. Family matters, including visitation rights. We saw this play out, obviously, in nursing homes across the country early on. Wills and advance directives, prison and jail conditions, nursing home protections for both people who are living and working there. Voting rights, obviously it's becoming an enormous issue as we inch closer to the election. Education, accessibility, and accommodations. Reasonable accommodations in the new laws for the disabled, gaining access to court proceedings. This is also a huge issue that I don't have time to get into, but we're seeing lots of issues around people who are being, for example, held to account for an eviction notice, but they don't have any way of reliably accessing the court due to connectivity and other technology issues. So these are not issues, really just like any of the issues I showed on that second slide. These are not issues that were brought about by COVID. They are just being accelerated by COVID. And of course, anything that gets accelerated by COVID is happening in inequitable fashion in communities of color. So let's turn our attention to eviction. Pre-COVID, about 20.5 million families struggled to pay their rent, but only about 25% of eligible renter households received financial assistance of one sort or another. So we have a huge renter issue in this country. We have a very relatively small program for assisting those renters with their rent. There are far too many people who are paying upwards of 50 or 70 or 80% of their total income to rent. What is deemed to be the normal or acceptable figure nation and worldwide is no more than 30% of one's gross income should be spent on rent or mortgage payments. So we had a huge housing crisis even before COVID struck. Back in 2016, which is when we have the most reliable data, thanks to a research study and Pulitzer Prize winning book by a guy named Matt Desmond called Evicted, he found that 4 evictions were filed every minute in 2016 when the unemployment rate was about 4.7. Today, the unemployment rate is about 3 times that level, so you can start doing some initial math. Those 4 evictions every minute in 2016 represent just under 2.5 million evictions annually in this country, which is far, far too many to begin with. It used to be about as recently as 100 years ago that eviction was rare in this country. It was not an action that was taken lightly by landlords, but now we're seeing about 2.5 million, and that's again pre-COVID. From 1934 to 1962, and that was when redlining was outlawed, 98% of federally backed mortgages went to white borrowers. And we're seeing this today in unequal distributions of home ownership across the country when you compare white owners to owners of color. Today, the rate of Black home ownership is about the same as it was when race-based housing discrimination was in fact still legal. So what's going on now that COVID has hit? Well, there were 44 states and the District of Columbia that enacted moratoriums back mostly in April. More than half of those have expired. The federal moratorium that was included in the CARES Act has also expired, and all but 9 of the remaining ones are set to expire by the end of October. So that gives you a pretty good sense of when we could see what is a feared and perhaps predicted eviction tsunami. Now, the CARES Act only prevented evictions in federally financed properties. So we're talking about 12.3 million renter households and just 28% of all rental units. So when you think about the CARES Act, when you think about the federal moratorium that was in place and that is being discussed again, and hopefully forthcoming legislation, you're still talking about only about a quarter of the renter households in this country. So do not be mistaken into thinking that the federal CARES Act moratorium or whatever is forthcoming is going to be covering most of the people in this country who have difficulty paying their rent. 25% of all households missed their June rent or mortgage payment. We're starting to get the July numbers now, and we're seeing slightly higher numbers. It's up to about a third of all households missed rent in July. As you probably know from reading daily in the media about the enhanced unemployment benefits, those ended back on July 31st. Congress has, of course, left town without doing anything about those. That was the $600 you hear being talked about in the media a lot, and it was that $600 per week that was helping keep people afloat with their rent and mortgage payments. The Census Bureau has found that about 45% of adults live in renter households that were affected by COVID-related job or income losses. So you're talking about almost half of adults in this country. And here's the bottom line. Without a nationwide moratorium and financial support to address past rent due, we're looking at up to 40 million people facing eviction, which is a truly terrifying figure. If it came to fruition, it would represent the most damaging housing crisis in U.S. history, including what happened back in the Great Depression era. 80% of the folks at risk, that 40 million, 80% of them are Black and Latinx individuals. So we're talking about a crisis that we know is potentially coming. We're talking about a crisis of unprecedented proportion. We are talking about an eviction crisis during a pandemic when people are most safe in their home. We're talking about a crisis where people are most safe not living in large groups of people in crowded conditions. And yet we are staring down this potential eviction tsunami and doing very little at the moment to counteract it. You will see some articles. I saw one yesterday in a business journal talking about how the expected tsunami has not yet occurred and therefore it must not be as bad as we're envisioning. And the response to that is it's probably likely that we wouldn't see these kinds of numbers for another 2 or 3 months, in part because FHA regulations require that people who are in FHA-backed living situations receive 90 days notice of an eviction. It's common for private contracts between landlord and tenant to have 30 or 60-day notice periods. And then there's going to be a period of time whereby an eviction might be brought, but it's going to get hung up in the courts for a little while, especially as more and more hit the docket. So the fact that we aren't seeing massive numbers of eviction cases yet will really tell you nothing. And so briefly, some information about the health effects of eviction. This is literally just the tip of the iceberg. I recommend, again, Matt Desmond's book called Evicted if you want a deep dive into some of the health, and we're talking mental, emotional, and physical effects of eviction. Matt did his doctoral thesis on this topic in Wisconsin and specifically in Milwaukee. And so he's using that as a jumping off point. He looks at, I think, 7 other cities that he was able to gain data on. And then he has started an eviction lab at Princeton University where he's expanding on that research and trying to expand it to a more nationwide effort. One problem is, and I mentioned those 2.5 million evictions earlier, one problem with the data is that those are only the evictions that go through the court system. That's where he's getting his records from. We know that there is a shadow eviction crisis going on even beyond those 2.5 million annually and having nothing to do with COVID, because there are lots of quote unquote unlawful evictions or evictions that may be lawful but that aren't going through the court system, whereby a landlord might simply lock out a tenant and the tenant doesn't have the resources or the time to be able to fight that eviction, and so they move on. So there are probably several million of those every year. So in terms of health effects, the children whose mothers experience evictions during pregnancy are more likely to be born either preterm or with low birth weight. Evictions are associated with food insecurity and lead poisoning, which cause lasting effects in children's development. And if you know anything about the lead poisoning situation in Michigan, and there was just a settlement reached in the last day or two, I believe. That too is the tip of the iceberg. There are about 3,000 locations in this country that have lead poisoning rates higher than Flint. And so while Flint became the most obvious point of crisis because of the pediatrician whistleblower there in Flint, it is really just scratching the surface of the problem. And for adults, evictions are associated with increased all-cause mortality, emergency department use, sexually transmitted infections, HIV treatment outcomes, drug use, exposure to violence, depression, suicide, and more. So the effects of eviction, we have found, are not obviously just related to housing. They are related to one's health and well-being. We know that the effects of eviction can last well beyond the quote-unquote fixing of the eviction. So if someone finds a new place to live, we know that the mental, emotional, and physical effects of that eviction and the effects on neighborhoods, both from which the person was evicted and the neighborhood into which that person evicted moved into, all experience traumas. And those traumas tend to be relatively long-lasting. So let me move off of eviction. Let's tackle the issue of preemption. This is the one that you probably have not read much about in the same way that you might be reading about evictions in the popular press. So as local governments seek to address the myriad health, social, and economic consequences of COVID, they first have to ascertain whether they have the legal authority to do anything. And this is because of something called preemption. Preemption is a legal doctrine that allows a higher level of government, so for example, a state, to limit or eliminate the power of a lower government level of government, like a local government, to regulate a specific issue. So preemption has nothing specific to do with COVID. It's not new to COVID. It is a long-lasting legal doctrine that typically has existed really between, at least historically, between the federal government and the state government. Federal preemption of state law and local law is fairly commonplace. It's in part due to the supremacy clause in the U.S. Constitution that gives preemptory power to laws that are passed at the federal level as opposed to the state level. But certainly in the issue of health and specifically public health, so much of that has been left to the states. And in turn, much of it has been left to local governments. Well, in recent years, and we're talking about the last 10 or so, preemption has taken on new meaning at the state and local level. So states have started to preempt localities from passing regulation or laws that would, say, limit tobacco use, that would limit the purchase of firearms, that would limit pollution and the like. So very traditional public health areas of regulation are now becoming a very political issue at the state level. The preemption that you see going on at the state level typically happens in the more conservative states, where conservative legislators are looking to preempt the power of more progressive localities to regulate in areas like tobacco, firearm, and pollution. The tug of war over this, like I mentioned, is nothing new, but it's really in that past 10 or 12 years that corporate and conservative interest groups have wielded preemption as a policy tool. The organization that is most behind this effort is the American Legislative Exchange Council, affectionately known as ALEC. They are an industry-funded group of state legislators that develop model preemption bills. ALEC is made up of about 1/4 of all state legislators in this country. They are not a small outfit, and they have been wielding a lot of power of late. So what might this mean in a COVID context? Well, this is the example you're probably most familiar with, Kemp versus Bottoms. That's Governor Kemp from Georgia. Bottoms is the mayor of Atlanta. Back on July 16th, Kemp sued Bottoms to void 3 of her orders that were rolling back reopening and mandating of face coverings outside and in commercial businesses. So this is the one that made all the news. The White House task force, apparently, in a leaked White House memo, not intentionally leaked, I would add, warned that the spread in Georgia in the past couple of weeks has been widespread, expanding, and the task force itself strongly recommended a statewide mask mandate. After that memo was leaked, Kemp partially relented. He dropped his lawsuit. He has altered his executive order to say that while businesses could not be regulated with respect to face covering mandates, he would allow localities to mandate the wearing of face coverings in public. So in that month where he intervened to preempt the mayor of Atlanta from issuing a mask mandate, There were 8,700 new cases in Fulton County, which houses Atlanta. I will let you, based on the statistics, do a little bit of math in terms of how many more dead people there are in Atlanta as a result of that month of dithering over mask mandates. But Georgia is not alone. 1 in 5 states have prevented local governments from implementing preventive COVID measures. We're not just talking about face coverings, we are talking about wage rates, we're talking about strengthening tenant protections for renters, and we're talking about expanded anti-discrimination protections. And interestingly, just to give you a sense on paid sick leave, an issue that has been talked a lot about in the media of late, in 17 states, they have no statewide laws on paid sick leave, meaning they don't say anything about it one way or the other. But in those 17 states, they still block localities from requiring paid sick leave. So in those localities, in those 17 states that might want to move more progressively to allowing paid sick leave, they simply are not permitted to do so because the governor or the legislature of that state has told them that they can't. Let's move on to some closing thoughts. I've focused on economic inequality, so let me keep that example alive. Technical issue here. So as late as the 1950s, economic justice was national policy via high taxes on the rich and far stronger welfare programs than we see today. For example, in 1960, the average effective tax rate paid by the richest 400 families in the country was 56%, while the bottom half of the American household paid 24.2%. By 1980, the 400 richest had an effective tax rate that had dropped to 47%. By 2018, that rate had dropped all the way to 23%. The effective tax rate paid by the bottom half, by contrast, had stayed the same, 24%, meaning that in 2018, for the first time in our nation's history, America's richest billionaires paid a lower effective tax rate than the working class. And that effective tax rate includes federal income tax, corporate tax, state local tax. This seems to be related to our sense in this country of individualism versus collectivism. And it would seem that over many decades, perhaps centuries, we have allowed our sense of individualism to overcome, perhaps overwhelm, our sense of collectivism. One interesting example is to look at the comparison between what we're experiencing in COVID versus what we experienced on 9/11 when we lost just under 3,000 people. We are losing more than 1,000 people to COVID in this country every day. As I mentioned, we're up to 173,000 and counting. You know what the response was to 9/11. It was nationwide, it was forceful, it extended overseas, and as horrible as it was, it is a drop in the bucket compared to what we are experiencing. Every 3 days in this country, we effectively take on another 9/11 in terms of lives lost. Now, this individualism might have something to do with what I'll call an empathy deficit in the United States. We are an actual outlier. This was research done, it was published in Health Affairs. We are an outlier in the very large share of people in this country who don't find it unfair that many people lack access to needed healthcare. I'm going to quote the study authors here. If only I could see my other screen, which I can't. But they basically say that the low levels of moral discomfort that we experience over income-based healthcare disparities, despite broad awareness of the issue and of unmet need, indicates a much more tolerant public for issues like not having health insurance as a result of issues, social issues, economic issues, environmental issues that are completely out of the control of the individual affected. So let's look at a bit of an action agenda. So because health is a hub with so many social, economic, and environmental spokes, you're not ever going to achieve anything that approaches health equity unless you have something that it looks more like broader social justice. So statutory rights to healthcare, restoring leadership around climate change, reforming the criminal justice system, including decarceration of our jails and prisons, something we really couldn't even achieve during the spread of a pandemic inside those jails and prisons, establishing new worker protections like a living wage, canceling or diminishing student and medical debt, ending hunger and homelessness, which, to be honest, is truly easily achieved. It's really just a political issue. Neither one of those things is difficult to stamp out. The rest of the world has been doing much better since 1970 in stamping out homelessness and hunger. We have been trending in the other direction, and ensuring the right to vote. Now, I put this list up here not because you have to tackle all of them or any of them. It's really a pick one issue. I think for many clinicians, this list looks pretty far afield from what you were trained to do and what you do in your day-to-day lives. But if the shared goal for all of us working in the health equity space is equitable health and well-being across populations, and if science is guiding our investments on these matters, then this is a pretty rational list. And that article that I mentioned at the outset that I think Harold would have you read around physician advocacy, I think points in the same direction, which is when you think holistically about patient health, community health, these issues have to be front and center, right? You know about the data around social determinants of health and their effect on individual and community health. Some research studies are now saying that up to 60 to 80% of all health is affected at the local and community level, and it's not so much about a person's genes, about their personal decisions, or about their access to healthcare, which probably makes up about maybe 20 to 40% of individual and community health. The rest of it is made up by things where these people live, where they are born, what their education levels are like, who their parents are, what their job is, where their job is, and so on. And so if you're focused on issues of social justice, if you're focused on issues of health equity, this is, again, I think, a pretty rational list.